तो indirect
Assalamu
ज़्यादा है।
alaikum.
वाले
Dr. Imtiaz, can you hear us? Dr. Imtiaz?
Yes, we can hear you. Can you
Okay,
hear us?
welcome back.
Thank you.
Our next case is of
Uh,
Mushtaq, which
okay,
will be performed by Professor Asif Gul. And
Dr. Basit will present the case to the Dr. Asif Gul.
Assalamualaikum. My patient Mushtaq Ahmed, 60-year male from Sahiwal, presented with complaint of epigastric pain for 2 months, jaundice and dark colored urine for 1 month. His LF test shows ALT 70, AST 46, alkaline phosphatase 919, bilirubin 12.5, out of which conjugated was 3.1, CA19 was 1318. Ultrasound shows significant dilatation of biliary channels, no focal lesion in liver, CBD 18 mm dilated, suspicious soft tissue along head of pancreas. CT triphasic abdomen shows pancreatic head carcinoma causing intra and extrahepatic biliary stasis, heterogeneous enhancing lesion with fat stranding seen in head of pancreas causing complete obliteration of CBD with significant intra and extrahepatic biliary stasis. PD 6.5 mm, liver enlarged, spleen enlarged, CBD dilated 18 mm, and gallbladder distended.
okay, thank you, Dr. Basit.
Assalamu alaikum everyone. Can you hear me?
Yes, sir.
Yes, we can hear you. What about the LFTs of the patient?
Bilirubin is 12.
Okay.
With the direct bilirubin, I think 9, and indirect is 3. Significantly raised alkaline phosphatase level about 1200 international units.
Right.
So we are dealing with the pancreatic mass causing extrahepatic biliary obstruction. Important points in the history is that patient has
Patient has epigastric pain for 2 months and jaundice and dark urine for 1 month.
any history of vomiting.
No, sir.
So before proceeding with these pancreatic masses or periumpillary masses, one must exclude in history and clinical examination with a succession splash of gastric outlet obstruction.
No, sir.
So in standard position, we are proceeding with the side view scope. Plan is to cannulate common bile duct and then stand the patient so that we can relieve the jaundice of the patient. Bismillah. So we have intubated the patient and moving through the esophagus downward into the stomach. So as this is the side view scope, you have a limited visualization of the organs like esophagus or stomach. So we have just entered in the stomach and you can appreciate the sphere gastritis, or you can say puckering of the gastric mucosa. So we are moving towards the pylorus. So keeping a pylorus on 6 ocula position, we will enter into the duodenal bulb, and you can see there is a puckering or nodularity in the bulb of the duodenum, passing a scope with slight resistance, approaching to the ampulla. So here we'll reduce the scope, locking the small vein and pulling the ERCP scope back. Appropriating the position of the scope, and can I have a fluoro image? So this is bulging ampulla or bulging duodenal folds. We'll have to search for the opening of the ampulla of water. So seems to be difficult cannulation. इन दोनों के दरमियान है. हाँ जी, हाँ जी. Can we give a space phone to the patient? Suction पे बंद करें. So ampullary opening is embedded in the folds of the distal duodenum. Seems to be long duodenal portion, I think. Any comment from the audience? Dr. Gayas, Dr. Shafqat, Dr. Yasir? Simple, huh?
Okay, so patient has long intraduodenal portion and ampullary orifice is right beneath the mucosal folds. So I think we should try to cannulate, and hopefully you should be using slippery wire.
Okay. Yes. So trying to cannulate in a 11 to 1 o'clock position. Wire. वो कर लें.
Can we have the fluoro image?
वो. थोड़ा सा और वो करना.
What about the wire? Is it 035 or 025 wire?
So 035 standard wire.
Right. So many people, they are using 025 wire now because it's more floppy and easier to do the biliary cannulation.
But the end is so floppy sometimes it curves and tortuous in a single attempt while we are cannulating. So sometimes it may cause a problem. What's your experience? Go kar lein. Fluoro?
So it can be helpful in such cases rather than causing the trouble. So our preference is 035, 025 wire, and especially the hydrophilic floppy wires.
Oh.
Because it is likely to slip through because of being soft.
It can make loop and easier to slide.
दिखाना फ्लोरो.
Fluoro.
Pancreatic.
Okay.
चलो छोड़
Right.
नहीं पर बैठ छोड़ डबल टिक exchange करें. So we have cannulated the pancreatic duct, which was also dilated on the CT abdomen, showing a double duct sign. So we will proceed selective cannulation of the CBD with double wire technique.
Any benefit of performing a small pancreatic sphincterotomy here, just to get an access better?
But
वो ट्रैक गलत भी हो सकता है उसमें ये
ट्रैक गलत बन जाता है तो बार बार फिर वायर in my experience then slip into the pancreatic duct. You have because already pancreatic duct is dilated. So if you make a pancreatic sphincterotomy, the next wire is most likely again will go to the PD side.
I think it is better to try the second wire first, and if it doesn't get the access, using
that will
double
just
wire
open up
technique,
the ampulla and
then you
give you an
may
access
be
to
using, anything else.
हौसला हो
So you see in this particular case, he is keeping the wire. If it was a small flat papilla, first time wiring, maybe we could think
Fluoro?
of removing it. But the guidelines are if the wire is in, even the single
वो
turn
करते
wire in,
हैं
we should be putting in the stent.
Fluoro?
Because there is a risk of pancreatitis.
There was a time when
थोड़ा सा
ये
वो-
डिबेट होती थी कि
ये
3 टाइम
देखिए।
गई कि 2 टाइम गई
In this particular
अब नहीं
बस।
case,
बस
where it looks like a difficult cannulation, then the
देख
wire
fluoro?
is there, we should not be using it. We should use it for double wire.
बैक वायर बैक थोड़ा सा इसको खोलते हैं देखते हैं कि अंदर कहाँ है.
So, what is your approach if the double wire technique fails to cannulate the biliary tree?
Place the papillotom into the ampullary opening and look at the fluoro image and make it more vertical as compared to previous one
Right.
to get access into the common bile duct. हाँ जी, वो नजर नहीं आ रहा क्या फ्लोरो हाँ जी अब ठीक है.
So there is a question. If you are having difficulty in doing the biliary cannulation, would you like to inject some contrast from the ampulla?
Actually, in the pancreatic cancers, there is a tight blockage distally in the common bile duct. We'll try to not to inject because sometimes it can cause a swelling, periampullary swelling, and make selective cannulation more difficult.
Right. But you see, sometimes if your cannula is fairly inside the papilla, we can inject a small amount of contrast. Contrast will give us a guideline where to do the biliary cannulation, number one, and at the same time it opens up the biliary orifice a little bit. So sometimes contrast helps in doing the biliary cannulation.
Okay, let's see. We can try it today now. वो हाँ, सही. ठीक. एक मिनट अभी
अगर डबल वायर पेयर हो जाए तो मेरा नेक्स्ट
वो?
स्टेप यही है स्टैंड डाल के उसको बताइए
फ्लोरो
Stand
फ्लोरो
but the problem with the stand insertion is sometimes the papillary orifice it gets
नहीं
blocked,
उधर ही जा रहा है.
and the second guide wire
आप सही नहीं
we find
दिखा
it
रहे.
very difficult to do the biliary
इनको जरा
cannulation.
ज्यादा
In
frequent
that
दिखाना
particular
चाहिए.
scenario, we can do
बताओ.
the needle line sphincterotomy.
वो तो दिखाएं उधर ही है. ये चली जाएगी असल में. हाँ, चलें ट्राई कर लें लेकिन जब तक हमें वो नहीं उधर ना अनुभव करें थोड़ा सा देखें थोड़ा चीज़ें और ऑर्गेनाइज करके चलें ना फिर हो जाएगा ये. नहीं अभी देखें ये हाँ अब वो करें आप.
पूरे पे फ्लोरो आ
कोई बात थोड़ा सा So we have stopped the suction, we have given antispasmodics, but there are still peristaltic wave. Any other option or clue or tip or trick to decrease these peristaltic movements?
Sometimes there is air extravasation at the site of biopsy port. You can check whether that is tightly closed or not. So that helps at time.
दिखाएं फ्लोरो, ये ना सब थोड़ा बने, थोड़ी सी और वो कर लें, वायर पीछे करें, वो कर लें।
लिखना क्या है सर, टॉपिकल लिखना क्या है,
नहीं आ रहा, चलो वायर पीछे करें, पोजीशन दोबारा बनाते हैं, अनुभव और वायर पीछे। हाँ अब वो करें, करते रहें, वो आप ट्राई करें, गई गई गई, अब यहाँ थोड़ा मुड़ेगी, हल्का सा अनुभव करके बाहर अंदर रखें, स्लाइड करें थोड़ा सा और इसको स्टेबल करें, पीछे देखो फ्लोरो, नहीं अभी नहीं गई,
कहीं गई एक वायर।
फ्लोरो मुड़ रही है,
हाँ ये सही है, सही लगता है।
थोड़ा सा ना मुझे अंदर स्लाइड करा दें, करते हैं एक मिनट दे दें, फ्लोरो आप गई वायर अब जाएगी। I think this is the point, then we should inject and check, हाँ करें, फ्लोरो चल इंजेक्ट नजर आ रही हो, थोड़ा सा अनुभव करके ना, फ्लोरो ट्राई,
नहीं वो कंट्रास्ट
कर लिए, दिखाएं, ये सारा गैप है ना, इसको इसने क्रॉस करके जाना है, हाँ ट्राई आप जाएगी, फ्लोरो
डक लग दी। हाँ
आप दिखाएं,
उस तो ऊपर निकला
वापस आ रही है, चलो कोई बात, अगेन फ्लोरो हल्का सा बो करें, बो करके तो साइड पे चला जाता है, हाँ चाहिए सही, इधर जा रहा था ठीक है, हमको दोबारा पोजीशन बनाते हैं, चल जाएगा थोड़ा टाइम, बैक वायर बैक और अनुभव, हाँ जी अनुभव और वायर भी पीछे कर लें, चल आप दिखाएं फ्लोरो, चलो नीचे से करें, एक मिनट है यहाँ से दिखाएं, फ्लोरो, हाँ ये दिस इज गुड डायरेक्शन, दिखाएं,
So can we gently push the guide wire further instead of poking the ampulla repeatedly?
we are putting just trying the guide wire, but the pancreatic
think-
mass,
Yes.
there is a filling defect you can well appreciate between the ampulla and the start of the common bile duct.
Exactly. So your wire is was in the right direction initially, and I think if you have the facility of trying another wire, maybe smaller caliber or more slippery wire, that will be more
4 to
helpful.
5 दें, एक दफा से ट्राई कर लें, ठीक,
Maybe Vigiglide or Olympus wire.
वो फ्लोरो, हाँ गुड ये पोजीशन अच्छी, ट्राई कर, गई
Okay, so there you are. Wonderful. मेरा वही चली।
हाँ जी
So the duct is hugely dilated.
So this is the proximal end of the stricture or narrowing. So, Dr. Gayas, how will you decide the size of the stent?
So we can clearly appreciate that the structure is right in the pancreatic portion of CBD. So 4 centimeter stent, maybe if we are using metallic stent. If we are using plastic stent, maybe 6 or 7 centimeter long stent would be sufficient in this patient.
And you will try to avoid cystic duct.
Uh, uh,
Leave it open.
if we are using a metal stent and the patient is not a surgical candidate, better to place uncovered stent. Uh, if we have on the CT, it shows that there is low origin of cystic duct. If the cystic duct origin is above the stricture, then obviously it should not be an issue, whether we use the partially covered stent or other stent. In cases of plastic stent, blockage of cystic duct is not an issue.
So, what's the opinion that should we place a pancreatic stent or not?
Yes, we should be placing the pancreatic stent.
Any other suggestion or option from the audience? In patient with a 60 years old and having a pancreatic duct, pancreatic mass.
But we have passed wire, so leaving patient with the risk of having pancreatitis.
Well, the purpose of placing pancreatic stent in this patient is twofold. Number one, preventing the post-ERCP pancreatitis, and number two, to reduce the ductal pressure because of pancreatic mass. That will give some relief of pain the patient is having because of the tumor.
So, thank you very much. We are going to place a pancreatic stent first.
So, would you like to inject some contrast in pancreatic orifice, or we will simply place 5 centimeter stent?
As we have already seen a pancreatic duct on radiology, CT scan, it's a wide duct open, there is no obstruction. I think there is no need of contrast injection.
Right.
5. Exchange. So, would you
7,
like
5
to put a contrast in a pancreatic duct?
So I think many people have the opinion that we should be placing 7 FR into 7 centimeter pancreatic stent. So we should at least cross the genu if we intend to reduce the pain of the patient because of pancreatic tumor.
Fluoro? So what is the size of pancreatic stent? 5 French, 5 centimeters?
7 FR into 7 centimeter, if that is available.
So why?
Because the tumor is in the head of the pancreas, and the stent should clearly cross the tumorous stricture, number one. Number two, we should not be parking the stent at the genu because that is the watershed area. We should place the stent tip at least in the proximal body at least. And 7 French would be having more drainage compared to the 5 French.
So you are considering recurrent pancreatitis leading to patient symptoms, epigastric pain and like this.
So the tumor is basically causing upstream pancreatic duct dilatation, and that is one of the cause for the patient with pancreatic cancer to have the pain. So if we, during the ERCP, place the guide wire in pancreas, our routine practice is to place a relatively bigger stent for the drainage purpose, not for the post-ERCP pancreatitis.
गुल साहब थोड़ी सी वायर पुश कर लें पीडी वाली.
Fluoro? Is it open? I think it's in the tail of the pancreas. Fluoro?
So are you going to do biliary sphincterotomy in this patient, or?
Yes, first we are putting a placing a pancreatic stent, and
Okay.
then definitely we'll have access sphincterotomy and then place a biliary stent.
So what kind of stent are you going to place? Is it metal or plastic stent?
As this is resectable on the radiology, we are going to place a plastic stent followed by definitive management, curative surgery, probably Whipple surgery.
What was the size of tumor? I think it was around 6 centimeter, I guess.
I don't remember. Let me ask and then I will tell you.
नहीं vascular involvement कोई नहीं
Pleural?
इसमें 6 centimeter है. I think we can place the plastic stent, or if we intend to place metal stent, we can better to use fully covered stent, and we should be doing the biopsy of the tumor to know exactly what kind of tumor is this, because it is very unusual to have uh, not to have distal mets or vascular involvement for the tumor like 6 centimeter.
Process slide. So we are
Yes,
going to place-
what is your practice in cases of CA head of pancreas? Because there's some data like in surgical specimen, 10% of the cases, the cause may be benign, like lymphoma and other, like in our cases, it may be tuberculosis. And such cases should be considered if the duct is not dilated, if the mass is in the head of pancreas and there is no ductal dilatation. In such cases, adenocarcinoma is less likely. But if, like in this case where the PD is dilated, there is double duct sign, what is your preference for tissue diagnosis? Like EUS, should we be going routinely tissue diagnosis, or only in those cases where the function status is good enough to tolerate chemotherapy? Because we are getting more and more of calls where the patient function status is very poor and patient may not be going for chemotherapy. Still, we are getting calls to get a tissue diagnosis. So, what is your thought on this?
I think it should be a multidisciplinary approach, having a surgeon in a scenario. Particularly in this patient, I would suggest to go for surgery, basis on double duct sign and all size of the tumor and not involving any vasculature.
Okay, so coming back to the question of Dr. Shafkat, if the patient is not fit for surgery or chemotherapy, obviously there is no role of biopsy in that particular scenario. It should be just the wastage of resources. Second scenario is where the patient is functionally good and we do not have the tissue diagnosis. I think
7 French, 10
if the patient is surgical candidate and
10
surgeon is
French,
ready to
7
take the
centimeter.
patient, we can
10
send the
10
patient straightforward surgery even without the biopsy. If the patient is borderline resectable or patient in MDM, it has been decided that patient should go pre-operatively chemotherapy or radiotherapy. We should be doing the biopsy and confirm what is the nature of the tumor, and we should be doing the more targeted therapy. Molecular studies can be done on the tumor sample so that the patient might get benefit of chemotherapy and selecting the chemotherapy drugs.
So we are deciding whether to put a straight or double pigtail stent.
Straight stent.
Sorry?
Straight stent.
Straight stent. Why not the double pigtail?
Right. So double pigtail stents, they are not good for drainage. So in this patient, where the purpose is to place the stent is to attain the drainage, the straight stent is a better option. Single pigtail.
Sorry, Dr. Gyas, I couldn't hear you properly. I was busy with the
Sorry.
double pigtail stent. What did you say?
Okay. So double pigtail stents, data says that they do not have the good drainage. So our purpose is to attain drainage in this patient. So straight stent would be a better option. Double pigtail stents, if we have done the sphincterotomy, duct is adequately dilated, we have an impacted stone, we can always place a double pigtail stent just to keep the stent inside the CBD. But for the drainage purpose, double pigtail stent is not a good option.
So how frequently you use to perform a excess sphincterotomy for placing a biliary stent?
So if we intend to place 10 French stent, which in this case is, so for 10 French stent, we usually do biliary sphincterotomy. If we intend to place 7 French stent for some patient, stent can be placed without sphincterotomy.
Okay.
Putting multiple stents, multiple stents can be placed if you are seeing the thick pus is coming out, and you do not have option
Ready?
of metal stent. Only those cases, because the drainage will be through the stent as well as in between the stents. So in that cases, you may be putting in multiple stents. So then in this particular case, there's only one should need only one stent.
So, as Dr. Shafkat, you have seen that there is a tight stricture or pancreatic mass causing obstruction, and we couldn't see anything coming out of the ampulla. How can we decide that this is pus or purulent discharge or not for the decision of putting multiple stents?
After first putting in first stent, if the pus is coming, you may be considering to put in another stent, but routinely in such cases we put only one stent.
After placing a matlab, if we put a first biliary stent, then again putting a wire is a difficult condition and situation, isn't it?
Obviously, if we intend to place, if we intend to get better drainage, the metal stent is an option, and they are freely available, and usually single stent is sufficient. So we hardly placed two parallel stents in such scenario.
So in this case, as we are going for the surgery, surgeon would be happy to have a metallic stent inside the common bile duct.
No, if the patient is potentially surgical candidate, obviously we should be placing plastic stent, because metal stent causes a lot of peri-stent inflammatory reaction, and that causes surgical resection at times very difficult. But if the patient is going for chemotherapy, obviously we should be placing metal stents.
10 French, 7 centimeters straight.
So generally, most of the malignant obstructions are sterile until you intervene. So there are very less chances of pus coming out in such malignant obstructions upfront unless you have intervened it. So for all practical purposes, single stent and very less chances of cholangitis or pus coming out of a malignant obstruction unless intervened.
So for these malignant, the patient has a resectable tumor and he has a good functional status. So any patient doesn't have any sort of history or on clinical examination cholangitis. So can surgery be performed straightforward with the bilirubin of 12?
It depends on the surgeon's preference.
Yes, it can be.
And the anesthetist preference. If some surgeons are very reluctant, and anesthetists, even I have seen them saying that patient should touch restrained bilirubin should be down, and generally up to 8 and 10 they are happy doing it. If it is more than 12 or 15, then generally all of them says that it should be drained first. But if it is 5, 7, 8, many of them will be happy doing it. It is easier for the surgeon if the duct is good, is dilated well. It is easy to operate, and if it is not intervened before the surgery.
So we have decided to put a 10 French 7 centimeter straight plastic stent. We have already placed a pancreatic stent. Now we are putting a common CBD stent. With a
आपने इसको dilate तो नहीं किया या
नहीं।
करना है?
नहीं, dilate नहीं किया,
Dilate
सिर्फ
नहीं किया?
access dot में किया.
Okay.
हाँ. बोल, बोल. So how many people in the audience will dilate this stricture or just have excessive tortmy and put a stent?
So many of us agree that we should not be dilating such stricture, it's a short stricture, and we can straightforward place the stent like.
So we have placed a biliary stent draining well while coming out of the duodenum. So that's all. Any comments from the audience, or should we stop the procedure and move to the next station?
Thank you,
Thank you
Professor
very much.
Asif. Thank you very much
Thank
for
you.
nice demonstration.